All right, so this brings us to this morning's first panel discussion, and really excited to have these thought leaders here next to me, and some of them are either potential clients or clients of mine already. So there's a lot of familiar faces over here, and a lot of familiar faces down there that I've already connected with, and in this panel, we are looking at a topic that is meaningful, stronger together. Right? Linking people, all right, lifting these communities, and reflects not only the theme of this conference, but the reality of the moment that we're living in, right? We can't live in the stress of the hospitals and what we're doing to try to keep ourselves afloat. We still have to think forward and care and improvement. And I think that having these meetings together, we're all in the same boat, and this allows us to grow. All right, with that said, please join me in welcoming Dr. Christine Alexander Rager, President and CEO of Metro Health Systems. Dr. Paul Hinchey, Chief Operating Officer of University Hospitals. Dominic Hobson, President and CEO of Neighborhood Family Practice. And last but not least, Leonard Stepp, CEO and President of Ashtabula Regional Medical Center. All right, fantastic. It's going to be a great discussion. I'll turn it back to Brian today. Thank you so much.
All right, well, thank you, Sal. Well, that was cool. All right, I guarantee, seriously, I think we all need to have that conversation with him. That's unique and new. But to ground us today in today's theme, let's start at a high level. When we talk about being stronger together, that can mean different things across all different organizations, and everybody here has an opinion on it. So, what does stronger together mean in the context of your work in the communities who you serve? And I'm going to literally go down from Paul all the way down to Dom regarding that.
All right. Good morning, everyone. Never want to be first. So, I think the challenges for healthcare are so complex, and I'll just use an example: social determinants of health. It's got health in it, so everyone throws that at the feet of health systems. And we are terrible at solving the social determinant side of social determinants of health. But we get pulled into this, and in some ways we are the convener of some of these solutions. I'm very fortunate to be this year part of Leadership Cleveland, and so as part of that experience, I have gotten to see Cleveland in a way that I hadn't seen before. I've been here for 5 years. There are an amazing number of resources and an amazing number of people committed to solving problems in our Northeast Ohio community. And so one of the takeaways from that, and from my perspective from University Hospitals, is we can't solve all these problems, and as big health systems, we tend to be a little bit self-centered, and we try and reach out and we try and take all these things on ourselves. What we're learning quickly is if we're actually going to solve for these, we have to engage folks out in the community that are incredibly talented, have great resources, have great connections to the community, if we're ever going to solve the complexities of what we're dealing with.
Chrissy?
So I'm a family doc by training, and so really I've spent the entirety of my career understanding the things that I can do within my sphere and where I need to pull in people that can complement or expand what I'm able to offer to patients. And so when I think about that on a health system level, there's a tremendous amount of complexity. And we are also a safety net hospital. So we, in and of ourselves, are not resource rich. So we're kind of like the family docs of the healthcare system, where we really have to reach out and have tentacles kind of far and wide and deep into the community to work collaboratively across the community to really bring to bear what our patients need to be able to live their best lives and achieve the kind of health outcomes that they want to achieve. And the joke I say all the time is, I work for Metro Health. I can get 13 cents out of every dime. And I can do that because I'm going to partner with somebody else who has that 1 penny to spare, and somebody else who has that 1 penny to spare, and somebody else who has that 1 penny that pulls it together, that then delivers for the patient and for the community. So I think that really has just been the focus of my career and the focus of our institution as a whole. And we can get into how that reduces cost and, leveraging all of that. Those questions I think are yet to come, but I'll leave it there.
Great. Leonard?
So similar to Paul and Christine, partner agencies are very important. Probably about 15, 20 years ago, one of the first population health conferences I went to, very similar to this, similar size, there was a graphic put up on the screen, and it was an iceberg. It showed the top of the iceberg, it was about 5 to 10 feet in the air. Underneath the water, it went down several hundred feet. That's what social determinants of health are. The surface is really, it's just this 5, 10 feet. No, it's really not. It's hundreds of feet deep. And hospitals and healthcare organizations have a really hard time putting their arms around those things. You look at transportation, food insecurities, literacy, health education. All of these things feed into decisions patients make. There's a lot of organizations in the community that are doing really good things, but we're still terribly siloed. Even in a small rural community, you think about, okay, you probably know everybody because it's a small community. Well, you go to a meeting, you go to a chamber event, next thing you know, you find somebody else who's trying to focus on trying to help improve the community. So trying to find ways to gather all those individuals together on a regular, frequent basis has been something that we've attempted to do, whether it's our nursing homes, whether it's a rural health clinic that's in the community, partner agencies. The better we can collaborate and keep our arms around the patient, we'll be able to have that impact. But to Paul's point, healthcare systems can't do everything, and resources are more limited now than they ever been before. So it's really that collaboration in the community.
Tom?
For me, we know that our organizations, when we say stronger together, that's strong financially, but I think more importantly, hopefully we have stronger outcomes for our patients. And as we consider ourselves the front door of our healthcare system, and what we mean by that is we don't have a hospital. In many ways, we don't have the subspecialties that our partners have. And so for us to truly support and make our patients whole, we have to partner. We don't have a requirement. We don't have an option to do that. And so we lean into that, and we've always have. But the point I really want to stress is that fragmentation is very expensive. For us, when we partner, if I send a patient over and they do everything I just did over again, that's very expensive for the patient, but it's also very expensive for our system. And so we have to reduce those silos. And to your point, stronger together means that we are intentionally partnering and collaborating in the best interest of our patients. And hopefully we can get to a place where our funding models allow for that to also be in the best interest of our institutions, because right now that isn't always the case.
So what I just took from that is our patients are our community, and we are all patients within the community. Good. Before we talk about solutions, it's important to understand the realities you're facing today. What are your top 3 issues, and how are your teams dealing with that within your organization? I'm literally going to start with Dom, and we're going to go backwards. So, Paul, you get a little bit of a reprieve.
Oh, no, I want to go first on this.
You want to Do you?
No.
Well, I'm sure that many of our challenges are the same, but the first one is going to always be workforce for us. We know, or probably for all of us, but our people are everything. They're our engine. They're the reason that we're here. They're the reason that we deliver and able to support our patients the way that we do. And of course, we are a smaller healthcare organization in a land of some amazing large systems. And so in many ways, we can't compete in the same way that they can for talent. And so we have to be creative around what that looks like for us. And many times just leaning into mission, culture, and some of those soft things that doesn't tie directly into income and finances. The other one I will lean into is just the current policy landscape. We've talked about, marketplace changes and those subsidies. There's, quotes out there up to 1 million to 5 million people losing their coverage from the marketplace plan subsidies going away. We know that the pending Medicaid changes that we're going to see next year, there's a SNAP changes that we're seeing now. And so those policy changes are creating a lot of pressure on our organizations and a lot of pressure on the patients that we serve. And then the last one I would say is transformation. One of the key things that negatively impacts organizations like ours, community-based, smaller nonprofits, is that we don't typically have the ability, the bandwidth to be transformational or to be innovative. And many times we're so focused on survival, there's no way you can focus on how do you improve the model of care, how do you improve how you partner, how do you improve how you collaborate if you're focused on surviving. And so I appreciate that at our organization, we've been able to pick our head up and really start to see the entire landscape of what we're facing as an organization, but also what our community is facing, and lean into transformation and lean into innovation with the focus on our patients. And so those are the 3 things that are top of mind for us right now.
Appreciate that. Leonard?
So similar to Dominic, those external forces, the changes in policy that are really affecting hospitals, they affect large and small in rural communities, things that, if you're seeing the Affordable Care Act changes, reduction in Medicaid enrollment, it's affected our ability and eligibility for 340B. 340B is a program that's probably on death's doorstep, which we all understand, but in some cases it's a lifeline for other services that wouldn't be available to the local community. You're able to purchase pharmaceutical drugs at a very reduced price so you can keep care close to home, because transportation is a social determinant of health. Everything's connected. You're looking at the executive order change that happened last September, affecting the H-1B visa process. It used to be $215 to process an application for an H-1B visa. Now it's $100,000. So every physician we bring in that's foreign-born medical graduate is $100,000. In a small organization like ours, where we draw a tremendous amount of candidates from Canada, we're so close, similar geography, similar climates, close proximity to family. That's been a tremendous impact to us. Workforce is always going to be there as well, but the last thing I'll say is really payer pressures. We're seeing a lot more prepayment holds, reimbursement challenges, denials, challenging negotiations. We've been excluded from quality programs because our N size is too small. So your insurance plan wasn't sold enough in our community and purchased that we don't have enough of your patients, so we don't qualify for your quality incentives to keep your patients healthy, to reduce healthcare costs. It's just a reverse dichotomy that we're in right now when it comes to some of the pressures we're seeing.
Chrissy?
I feel like I want to say, yeah, what they said. Next. Workforce, for sure. I think we're all still struggling with workforce. The changes in policy and what it means for our patients, absolutely critical. 70% of the patients we take care of have government-related coverage.
Paul?
So that's a huge hit, right? And then technology, which is coming at us so fast and furious, and will help us be better, costs a lot of money, right? Takes a lot of energy. So I would say those are the top 3.
I saw you brought your IT team here to the table, which is great. So
I'll tell you.
giving you guys a shout out.
So you can see why I wanted to go first, right? So I'm gonna have to think fast. So the problems are the same. I'll put them in sort of dyads. It's not just the labor shortage. It's the labor shortage in the face of increasing demand.
Yeah.
We have, the nation is aging. The number of younger people to support the older people, that ratio is getting out of whack. It is worse in Ohio. It is worse in Northeast Ohio than it is in Ohio. And in some of our counties, like Lake County, some of those are the highest in the country. So we have this rapidly increasing disparity between the number of people available to take care of this increased demand. I jump on the cost and price bandwagon. We have more and more downward pressure on our revenue stream. No one wants to pay what people are paying for health care. And that's not a judgment on that position, but it is a reality for the health systems, because what we're reimbursed is relatively inelastic. It's fairly fixed, whether it's set by the feds or set by long-term contracting with our different payers. Our costs are completely elastic. We are subject to all of the constraints of labor, which drives up costs, all of the constraints that come with inflation that we are subject to rapidly narrowing margin pressures, and frankly, we're running out of ways to take cost out of the system. And then the last I would echo is the technology piece. There are lots of solutions out there, all looking for problems, and it is becoming increasingly harder. No offense to our jury folks, but it's increasingly hard to figure out how we use AI to the maximum benefit. Some cases like jury may have a really good ROI built into them, have a good business case. There are tons of solutions out there just begging for a problem, and I can't keep them all straight. There's so many of them. And just the cost of the healthcare technology is going up so fast. In the face of the margin pressure, it's really hard to figure out how to pay for all that new technology. And you want to do it for the community, you want to do it for the care, but someone's got to tell us how to pay for it.
So at 1:45 this afternoon, and I said this to a few folks up front, we're having a special guest come and present around a lot of these core issues. So if your teams are here, I ask that you stay, listen, because the slideware of every single issue that these leaders have actually just put forth are going to be addressed, and then there's going to be additional magnitude associated with that that you all need to plan for. So given those challenges and collaboration is often positioned as part of the answer, but let's talk about what it actually looks like within practice. And so in an environment that's increasingly challenging for providers, how can collaboration help you navigate these pressures? Now, who should we choose first? Paul, that's great. Paul.
All right, we've turned this into a game now.
Yeah, right?
Brian has an unfair advantage. Yeah, so I mean, I guess I'll start with, maybe I'll take labor and we can, we'll split it up or something, so I don't. I think we've got to come up with a labor solution. That is, the theme of this being partnerships and collaboration. I think we need to work more and more with our community education programs that build our pipeline for our future care providers. I used to be a college professor. I understand the constraints that come with that. We need to better, as health systems, we need to better understand what that is, whether it's precepting sites, educators, creating enough resources to open that pipeline. Because right now it's constrained for very real constraints from the education side. I think we're going to be forced to think differently about who we use to take care of people. We're forced into a construct based on how we're reimbursed. One of the upsides to a value-based model is we can unhitch ourselves from that fee-for-service model, and that takes away a lot of the regulatory requirements about what you can bill for, and we can actually deliver care with all kinds of different providers that don't fit in a traditional construct. Paramedics, community health coaches, community health workers. There's all kinds of things that we don't leverage to the extent that we should today, because we've been built around a construct of using more traditional billable billing providers, and we're just not going to have the resources left. It's going to change where we deliver care. It's going to move more of that care into the home. We're going to be more dependent on family and others to be part of that caregiving model, and we're going to be more dependent on community partners to close some of the gaps that large healthcare systems are just not going to be able to figure out how to solve for.
So Dom, I'm going to change it up now. I'm going to have you go next because of what Paul just said.
Well, I was expecting to go last on this one. I appreciate that Paul. And for this question, I think one of the things that really jump out to me is that we have to partner and leverage expertise. One of the things I love about being in Cleveland is that we have some partners that do so much great work. And we talk about how leveraging technology is expensive or when it comes to solving problems, but what it is really expensive at solving problems is when we're trying to reinvent the wheel ourselves. They're doing some amazing things already, and sometimes we can't implement them in the same way because we don't have the same expertise or the same team members, but there are things that we can learn. And so I am always calling on our peers and our colleagues to say, hey, can we benefit from that? Can we learn from what you're doing? How can we look behind the curtain, I would say, because our ambulatory care operations is much different than a hospital-based system in their reimbursement model. but they've been able to do things in a very creative way that results in better outcomes for their patients, especially when it comes to managing chronic conditions. And so how do we lean into that to help learn and partner and collaborate that benefits our patients, especially our shared patients that go across multiple and all of our institutions?
That's great. I'm going to go to the next question, and I'm going to give it to Leonard and then Chrissy, and that is, where do you see the largest gaps today in how organizations collaborate to serve communities?
You want me to go first?
Sure.
Okay. So I think the challenge around this is that there is still competition within the market, right? So, and there's a phrase that gets tossed around, kind of merges competition and collaboration, because in some ways, like within healthcare, competition is important because it pushes us to be better and better and better, right? The whole idea behind value-based care is how good can you get at managing a whole wide array of things that impact somebody's health. Diabetes, high blood pressure, et cetera, right? So you want us to be competing on that. You want us to be like, oh my God, Dominic's people are crushing this. What are they doing so right that we can do for our patients, right? So there is a bit of that that's important, but just a bit. Right? We have to figure out how we collaborate together on all the rest of it. Because if we're doing it in silos, are the patients really benefiting? Is the community really getting healthier? No, they're not. So how do we meaningfully partner, especially when we know the workforce is limited? How do we share the limited resource, right? Do we try to go hire our own cardiothoracic surgeon because Paul has a cardiothoracic surgeon and, CCF has a cardiothoracic surgeon, so we want our own? Well, then that creates a competition that drives up costs that doesn't necessarily improve outcomes. Because in some of those situations, the way they get better is by doing a lot of it. So if we're all doing it, we're diluting those opportunities for people to get better and better and better, right? So how do we have the aha moment around how many does the population need? Okay, you've got that. You've got 3 of those. I'm not going to hire one of those. But I'm really good at this thing. I'm really good at rehab. So I'm going to have 3 rehab docs, right? And then I'm going to share those resources with the people in the community who need it so they don't have to because they're doing mainly ambulatory. So how do we partner up to make that happen? I think that's where we need to move toward. I mean, honestly, we're coming to a question later that we're going to talk about this. I just want to blow up the whole darn system and start over and say, let's just all start with collaboration and figuring that out, right? And then figuring out how do we really share resources in ways that are important and still hang on to that little bit of sense of competition and make sure we're pushing ourselves to be even better than we think we can be with the idea that's going to make our community healthier.
That's awesome. Yeah, Leonard?
I agree. Keep the patient in the middle.
Right.
Compete on quality, not on patient encounters, because then you'll reduce waste. Taking a slightly different angle at this, looking at it from a broader community perspective, we get pulled together every 3 years to repeat a community health needs assessment. It's a great collaboration with the community, all the resources, all the agencies that are there. There's no intercycle reconvening of those groups to talk about how well we're performing. Are these the right things we're paying attention to? Do we need to celebrate these successes? Do we need to put more resources into them? I think that would tremendously help close gaps. It's a checkbox at this point. It's something we're required to do. We got to post it on our website and then come back together in 3 years and try to find a way not to increase the consultant fees that are related to that effort. So we got to change it from being an exercise to actually being an actionable plan that we're all collaborating on and not doing it in silos.
Thank you. All right, well, let's talk about some examples. And so I'm going to turn it over to Dom. Can you share an example where partnerships across organizations made a meaningful impact and led to overall improvement?
Yeah, I'll share an example of our partnership with Cleveland Clinic, and particularly their Fairview Hospital. And so we all know the least expensive place for people to receive care is in a primary and preventative setting. But so many in our community don't always utilize those settings the way that they need to. And what I mean by that is we have a number of our community members that are still leveraging and using our emergency departments as their source of primary care, which is very expensive and it impacts all of us. I think when we talk about health policy, we talk about that problem as if it's just a small group of people that it's impacting, but literally it drives up all of our costs, and then it factors into when our employers and our payers are negotiating for rates because the cost is so expensive at that level. And so one of the ways that we tried to solve that is how can we help make sure that those patients that are not connected to primary care and show up to the ED or that are being admitted to the hospital system get the care that they need, and then walk away with the connection to a primary care provider that hopefully reduces the need for that patient to come back. And so this started as a pilot about a year ago now, where we went to one of our funding partners, the Community West Foundation, and said we would like to place one of our employees, neighborhood family practice employee, inside the ED at Fairview. And so they were willing to fund that for a few months of the time, and we placed an experienced employee there that really knew how to help patients navigate all of those social complexities that then feed into their medical complexities. And so the primary role was that every patient that showed up, regardless of their insurance type, uninsured, Medicaid, Medicare, commercially insured, that was not connected to a primary care provider, she had a referral for them. And she would go and see them in the ED or at bedside to say, hey, we see that you've come to the ED multiple times over the last year or so. I work for Neighborhood Family Practice, and we would love to connect you to a primary care provider where we have an expanded care team that can help support you and hopefully keep you from coming back to this hospital. And for those patients who were willing to connect, we saw a decrease where at times the readmission rate was around 13% for these patients, because they are some of our most complex patients that we have in our community, and that was brought down to 5%. And again, I don't work in the hospital system, so I don't know what that means to a hospital's bottom line, but I know that from a healthcare, value-based care, and from an incentive model, that helps everyone. And more importantly, it helps those individual patients, because what that means is they are able to then stay healthy, stay whole, be a better member of our society from a productivity standpoint, and then hopefully be more active and engaging with their family members. And so that's now a year that we've been doing that. And we've pivoted to model now where it's actually a Cleveland Clinic employee doing that work on behalf of our organizations. And it's been very beneficial for all of us, because we are able to make sure that we're supporting the patients who need the most care, again, those patients who have the most social and medical needs, and we're supporting them, and then we're hoping and helping keeping those patients out of our ED and out of the hospital, which helps bring the cost down for our whole system.
That's great. Thank you. Yeah. Good one. So real impact like that doesn't happen by accident. It often requires leadership to step in forward ways and as well as many ways. What responsibility do healthcare systems leaders have within our community to drive collaboration beyond their own organizations? And so, Paul, I'm going to start off with you, and then go to Leonard, and then Chrissy.
Yeah, I
Get
think,
done in a minute.
I sort of referenced this at the beginning. I think, big healthcare systems tend to try and engage and solve for these problems ourselves. And I think the challenge with that is we're increasingly learning we can't do that. The upside, I think, to being a larger healthcare system, though, is one of the things it does give us is a little bit of perspective on how to link where all the different points are in the system where we fail around taking care of a patient. It is so complex, it is so matrixed, there's no silver bullet to any of these things. So one of the things that I get to have a little bit of perspective on is where we create gaps. And I think that's an opportunity for us to lean in and try and solve for some of those, agnostic to the health system, agnostic to the site of care. And I'll use an example. So, Chrissy and I, the folks from Cleveland Clinic, many of the folks in this room are all working together around Medicaid enrollment. It has become so challenging. The challenges ahead of us to keep people enrolled in Medicaid, keep them on Medicaid. This isn't about UH capturing Medicaid patients. It's knowing that if we work together and sign folks up, everyone in the community benefits, most importantly, the patients who have continued coverage, because they're going to end up in my shop, they're going to end up in Chrissy's shop, they're just as likely to end up at the food bank, they will certainly end up in Dominic's shop. We all have to come together to solve for that problem, and I think that's one of the things I think we've done a really good job of trying to coordinate around that and drive an impact as a system and as a community.
Leonard or
Do you
Chrissy?
want me to take that?
Yeah, Chrissy, go for it.
So for us, it's a lot of that same sort of work at, looking at kind of like what Leonard was referring to, really looking at your community and deeply assessing your community. I've always been a big believer in get out to where the people are instead of sitting in your office waiting for them to find their way to you. All right, so this was the whole idea behind the school health program. We actually have the woman who helped create it here with us today. That we noticed that kids weren't getting their care, they weren't getting their vaccines, et cetera, et cetera. Where are kids all day? They're in school, right? So reaching out to CMSD to say, okay, how can we partner with you? How can we bring care to the schools? And then that way, that's the least disruptive to the kids' school day, instead of what was happening, where the family would go take the child from school, take them to the doctor, and then not return them to school because there was no bus to take the kids back that day, right? Like all those sorts of barriers, right? The food bank, Kristen, Rockstar, right? How do we put healthcare right into the food bank, right when they're coming to get the food? And then creating classes to say, how do we help you make the healthy choices based on what your disease states are, right? And so I think it's really just thinking about the patient in a different way, and how do we get to where they are? I mean, I could go on and on. Taking care of people at the jail. If you get people healthy when they're in the jail and you get them connected to care as they're leaving the jail, the healthier they are, guess what? The healthier you are, because they're taking less resources, right? So it's a bit of that. Think about the gaps, think about where the people are. How do you get to where they are?
Leonard?
Yeah, forward-facing is definitely the way to be. We also opened a school-based health clinic about a year ago. It was the first one in Ashtabula County. We also offer a community advisory council where we have about 40 or 50 members from the community that come in on a quarterly basis. We provide them a few updates that are happening around the health system, and then we leave the rest of the time for their feedback on what the community's saying. It's really enlightening what we hear from those community stakeholders, but what information they take back out to the community is also vitally important. We're very fortunate in the sense that 90% of our caregivers are Ashtabula County residents, so we really do have the community as a part of the fabric of our organization. So every day we're talking to our community ambassadors, and they really are our biggest organizational ambassadors. So we have a captive audience, so the things that we're hearing inside the four walls really are emulating what's happening in the community, and that's really been beneficial to us.
Thank you. At the heart of those community connections is something we often talk about, and that's trust, right? What are some of the challenges in building lasting community relationships, and what role does trust play? I'm going to go to Dom first, and then I'm going to go to Chrissy.
This is a very tricky topic, I would say, for organizations like Neighborhood Family Practice, primarily because when we partner, especially with our larger institutions, there's just a built-in dynamic where they're much larger than us, right? And they have much more resources, legal, regulatory, all those things that we don't have. And so, and many times we come to the table with less information, less knowledge, and less resources. But we also have to make sure that we are centering why are we here, who benefits from a partnership, who benefits from a collaboration. And I think once we do that, then you start to break down some of those trust barriers that you have, and you continue to center the patients that we serve. And so I think that is the biggest way that we help do that, is making sure that we're on the same page of when it comes to what do you all get from this, what do we get from it, and it doesn't have to be the same. We both need to benefit, and then ultimately the community or the patient needs to win more. And when we approach it from that way, it reduces the risk and the fear about partnership and collaboration, and allows us to really lean in to say, does this make us a better organization? Does this provide better resources to our team members? And does this lead to better outcomes for the people that we are serving?
Chrissy?
Yeah, I would agree with that. I think for me, the patient always has to be the center of every single decision that is made. Every single collaboration, it has to always be about the patient. And I think it's a little easier for me to have that view because I've been a doctor for almost 30 years, right? And so, and this is what I would preach to the medical students and to the residents, right? It is always about the patient. And I think when we come together as organizations, you know, like it's funny to me because when Dominic thinks I'm a big organization, I think UH is a big organization, right? Like it's a matter of scale, but as long as we're unifying around that, what is best for the patient, right? How are we getting there together? Then a lot of that other stuff, the other, you know, competition type thing can fall away because we're centering ourselves on doing the right thing.
Thank you. As we look to grow and sustain collaborative work, measuring impact becomes extremely critical, and we've heard it numerous times already. It's not just about the accountability, but it's this towards sustainability. How do you measure the success or impact of collaborative efforts within the community? I'm going to start with you, Chrissy.
Yeah, and it can be really, really tricky, you know, measuring your outcomes. We do a lot of work around social determinants of health. We have an Institute for Hope. In case you want to talk to them, those guys are here too. And we really look at the outcomes, right? And when we look at outcomes, we're really drilling them down to, you know, this neighborhood, this zip code, this type of demographic, what's happening with breast cancer outcomes for young women who are at this level of income, right? We track those databases very tightly. When you have that already developed, now you can layer on, okay, if we're starting to, for instance, send our mammogram van to neighborhood family practice sites, how are we changing the data? What neighborhood did they come from? How are we categorizing it? It can be done, but it's pretty sophisticated technology that you have to utilize. But again, it's back to the idea of what's important to that patient, what's important to leveraging their health care. Is it really getting their A1C every 6 months? Well, what's that doing? If their A1C is 13 all the time, you're not doing anything for that person. But when you improve that A1C below 9, now you're doing something, right? When you get that screening and you move to the diagnostic mammogram and you get the biopsy and it is not as severe a cancer, that's a meaningful outcome, right? So there are things that can be tracked. You just have to be able to develop that system and then layer on when you're partnering with others and knowing how you can tag it within your system. But I would encourage all of us to not just look at, I think it was what you had said, Leonard, like don't just look at the checkbox things that you have to do for the insurance. Look at the things that are real, that make real impacts on outcomes for the patients.
Paul, you got some thoughts on this?
Yeah, I mean, I think Christy's spot on. With enough money, you can solve any problem. But the reality is that you may only be able to solve one problem. And that's just not how healthcare works and how caring for populations work. It is a vastly interconnected network of dependent things. I think sometimes we try and boil the ocean. And, you know, I guess one of the challenges I put to the group, and I take this myself, is that, so in a past life, I used to run big EMS systems. And the one group that sees everything that happens in a community is frankly the EMS folks. So we may look at, you know, how many times a patient, you know, they came to the emergency department twice this month. Wow, that's a lot. But what we don't see is they went to everyone else's shop 3 or 4 times a week. And in the aggregate, they've gone multiple times. 1% of the population uses 25% of the 25% of the healthcare costs. Now, many of those are insured, right, just because they're older, but there's a whole subset of that population that isn't. There is a population out there that if we agreed to target a high-frequency utilizer group, that we agreed to target and brought all the resources to bear around that population and measure their recidivism, their use of the system, and how can we intervene on behalf of those folks? Because it's a really small number. I mean, if you think about, if it's just 0.5% of the population, we can manage 1,000, 3,000, 5,000 people with intention. But we have to coordinate around managing those people to help them, because everything we do to benefit that population that maybe is disadvantaged, doesn't have transportation, all the other components that we need. Stamping out homelessness by itself doesn't solve the transportation problem, doesn't solve the access to behavioral health, doesn't solve the issues around medication. We've got to bring all the resources to bear for a population that is most needy. And if we can drive that utilization down, drive the care up in that population, and manage that population better as a community, that will benefit all the other folks that also have a lot more resources. So as we look to measure, those are the targeted populations we should collaborate around trying to solve for.
I agree with that. Thank you. If we bring this back to what leaders can do right now, and there's so many within this room, there's likely some very clear opportunities to move the needle. What is one action you believe leaders should take to better support collaboration and strengthen their communities? Before I turn this over to Dom, so you have a minute here, I want to thank Paul for handing me from the Cleveland Leadership Center, shout out to you, a challenge coin. And I want to state openly, it means the world to me, but this is an accountability associated with leadership. And I just want to state openly that I not only accept your challenge, but I'm so thankful to have CLC attached to our organization working strategically. So, Dom, you've had a minute now to prepare. So are you ready?
Yeah, for
Good.
sure. And of course, I'll continue to give the Community Health Center perspective in a question like this. But the first thing I would challenge smaller organizations, social service providers, to know what we need from our partners. So often we complain that Cleveland Clinic or Metro Health or University Hospital, they won't partner with us. But what really is happening is we don't know where we need support. And so when you have an opportunity to come to the table, you need to be very clear on what can we use that you already have, that doesn't result in you spending more resources, that allows us just to plug into a system that's in place. And so I want to challenge the smaller partners in that collaboration model to make sure that you understand what your challenges are, what your barriers are, and then what can you use and leverage that your larger partner already has. And then I would challenge our larger institutions to say, bring organizations to the table earlier. There's countless times over the last decade or longer where we are brought to the table right at the end, where there's been meeting and discussions and all those things going on for months. And then they say, well, hold on, we forgot we need FQHCs or community health centers or community behavioral health organizations at the table. But now the model has been developed, the funding, the resources have been divided up, and then we're asked to carry things that last mile. And that's not fair to us, and it's not fair to our patients that we serve. And so those are the two things that come to mind for me. Again, for smaller partners, know what your challenges are, know what your pain points are, and ask the question. And I would say be persistent. I think our colleagues here will tell you I am always calling and knocking and continue to ask for things for support because I know that they can benefit our partners. I know that they can benefit from our organizations. And so you have to be persistent with that. But I think those are some of the ways that we can help solve for this problem.
Leonard?
I think it starts within the organization in having established visible goals that are cascaded down to the departments, and then departments taking those goals and extending that out into the community, whether it's serving on a community board or going to a local chamber meeting, talking about the things that are happening. It's interesting how many collaborations start out of sharing things that we're working on. It's like, oh, we're working on that as well. We learn things every time we're out in the community. Setting that basis internally and trying to establish a highly reliable organization, one that your caregivers are able to make decisions. They own what their work is and their space, and so they bring partners to the table that we otherwise weren't aware of. We always talk about, we want to be responsible for everything, but we don't know everything. So, the only way we're going to be able to do that is to give the confidence to our teams to go out there and bring things back, lead, and actually control what's going on. Because otherwise, we're not going to be able to collectively impact anything if we're all trying to do it out of the admin office in one building.
Thank you. Thank you. The AV team, just so you know, if you're wondering what this is not a teleprompter. This is a very large clock. And I have direct communications with a full team in the back, which I've already given gratitude to. but they've been stating openly that we're now back on track, which is good, right? So we got 2 thumbs up on that. And then I want to go to the last question so that we can ask openly, allow you guys the opportunity to ask questions. But one of the messages that popped up here was, number 1, go Monsters tonight. Okay, you can applaud on that. All right. The second one, though, that he wanted me to promote was Cavaliers. Go Cavs. But it was funny because the team up here is oblivious to it because they're so focused on you and stuff. So anyway, but let's conclude by zooming out and thinking bigger, beyond current constraints and into what's possible. And you know this is part of my favorite questions, which is the magic wand question. If you had a magic wand, what is something you could change about the healthcare system to make collaboration easier? Paul.
I would love to find a way to align incentives. I think the health system is broken largely because of the challenges around aligning incentives. You don't have to be too many degrees off orientation to not be aligned and to create real challenges for us to solve for the problems in front of us. And that we have to figure out how to solve for that. We have to figure out, we won't be able to control all of it because, there's too much pressure against the national health system. That's not gonna drive the alignment. But we have to figure out how to align incentives. And Chrissy touched on it before. We're all doing the same things. How do we get better about working together and giving up some of that control to each other to let others solve? So we start to bring the work that all of you out in the community are doing, the health system are doing. How do we start to bring that into better alignment? Because the patients will always benefit from us being better aligned around how to solve these problems.
Agreed. Chrissy.
How big is my wand? Is it a really big one?
It is a vast one. Do it.
Blow up the U.S. healthcare system. Truly, I would blow up the U.S.
not joking.
healthcare system and build a new system that truly, the foundation is primary care. And then that way you can align those systems so that if we all are focused on providing outstanding primary care, you then can lean into, okay, maybe you're taking the lead on this and this other system is taking the lead on that, right? It is that idea that we can look at the community more holistically and say, this is what we're good at, we'll take care of that, and we're gonna give this over to you, and we're gonna do it more collaboratively because we're really focused on the patient and the community as a whole.
Leonard?
I would say modification of regulations. Hospitals have a lot of resources that can help partner agencies, but then you trip over rules that you don't realize you're tripping over, whether it's Stark, the anti-kickback statutes. There are creative ways to do things appropriately, but it's very, very difficult. So if you have an EMS department that needs a Lucas device that's going to help provide chest compressions, we have the ability to share those resources. It becomes very tough. So we can get into a lot of really risky situations that we get pointed in opposite directions from by our legal advisors to say, don't go there, it's too risky. Dominic, you may have experienced this going into larger healthcare organizations and they're saying, man, this sounds like a great project. We'd love to support those resources, but legal said no. So, if there's one thing I would want to wave my magic wand would be to find ways to make appropriate changes to regulations to better help support community agencies that take care of the patient.
Tom?
I have to go in and lean in with Chrissy. Again, our organization is really hyper-focused on that front door model, that primary care and preventative model. And so for us, we have to have a stronger investment in that space. We know what our healthcare spending is. We know that we talk about we have the highest, expenditure, but some of the worst outcomes, especially for developed countries. And so that's a problem, but the system is not going to change itself. There's too many people in line that are benefiting, whether that be from financially or in other ways, from our current model for it to be rapidly changed. And so for us, I think it has to be a more strategic and intentional investment on primary care and prevention. And then going back to the first question earlier, breaking down those silos and that fragmentation in our system, because it's very expensive, as I mentioned earlier. Whenever our patients are having very much a difficult time to navigate and coordinate their own care for our systems, nobody wins from that. And so whenever we can break down those silos and be a more connected system, a true healthcare system, as opposed to having individual institutions, and then we'll be able to lean in, and I think we'll have better outcomes because of it.
Thank you. We're going to open it up to some audience participation questions. So, please.
Hi, how's it going?
Here comes the mic. There you go.
Really encouraged by a lot of what you had to share today, especially on the idea of the necessity of collaborating and how social risk does translate into insurance risk. So with that idea, knowing that all of you have some version of downside arrangements in value-based care, what do you need to do to incorporate community-based organizations and others into your shared savings or downside arrangements?
Leave it to Lauren to ask the hard question. I think I'll take a stab at that. I think, Lauren, it gets back to that idea of us doing the work of identifying the gaps for our patients, and you really have to lean into that a lot and try to get to the root of the gap, and then figure out who's doing this in the community, who's helping this type of patient. And how do I create something with them that then they share in accomplishing, right, that care for the patient? And if there's a way to then share what you get in value-based quality as a result of that, again, the lawyers would get involved and all of that, and it's the incentive, and it's all that, right? But if we say, okay, how are we, I'm just gonna pick a random, like, how are we helping patients with hearing impairment and make sure they, right? And then partnering, with the agency around that, I think there could be potential there. But again, I think it's back to that idea of we would get so stuck in regulation and rules that I think it would be hard to accomplish. But what a wonderful thing it would be for the patients to be able to work in that way.
Yeah, I would love a capitated model that would give us the ability to engage more and more people in the community and find a better payment structure to help support all the work that our community partners do, instead of what we end up doing, because those things don't exist. We try and build it on our own, and it's I mean, Leonard mentioned before, it's incredibly inefficient that we keep rebuilding redundant structures.
Yeah, I'll just add one thing to that. Most of our value-based care, well, I'll say all of our value-based care arrangements are primarily upside only. The ones that are downside, we're able to come to the table with a much larger partner and on a national scale. And so for us, I think it is being creative and finding ways to share those resources where appropriate, share some of those risks, and then also share the value or the benefits of that work. And we're still working through what that looks like. I think what we found is that most of our organizations that are like us are not ready to lean into downside risk because of the fear that comes with that. We've looked at our data, we've looked at our outcomes going back over multiple years, and we feel like we're prepared to do so, but there's those regulatory constraints that get in the way of those opportunities to do that, and so we're always trying to lean in and find those creative ways to help solve for that problem. But great question, Lauren.
Others? Jody.
So as I walk through the halls of Congress and talk to policymakers, the pain point is healthcare affordability. Can you address the pain points that contribute to healthcare affordability from your provider aspect? Because we hear we have to control cost. How can we best do that?
So I would say it's back to this idea of how do we collaborate on the things that we know are those really high-cost healthcare needs, right? Like, why would I hire a CT surgeon if I could collaborate with one of the quaternary providers in my community for CT surgery to be provided, right? Because every time we step in to create a duplicative service, guess what happens? There are fewer physicians that do that work, so therefore we're competing for the same folks. So what happens? Wages go up, right? So then if wages go up in one place, they have to go up in all places. Wages go up, there goes healthcare cost. Who does that get passed on to? If you're me or you're Dominic, it gets passed on to the government because we're going to ask for more supplemental payments to stay alive. And if you're UH, you're going to the commercial insurers and saying, you have to pay us more money because we have to afford these wages, right? So we need to stop duplicating services where we think we have enough resource for that community, right? Stop doing that and share the resource already. We don't have enough people going to medical school. We are not producing physicians. We're supplementing with PAs and NPs, but they're not going to step into a cardiothoracic fellowship after, a surgery residency, right? So we have to really be thinking about these high-cost things and how we lean into those collaborative relationships so that we're not just duplicating services and here go the costs, up, 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 up. That would be my recommendation.
So taking care of the patient in the right setting of care. So if they're a high utilizer of emergency services, how do you get them to a outpatient visit or an urgent care or an express care? It's amazing, even within our own small organization, that the lack of coordination around patient transition from acute to home health or skilled nursing wasn't happening, and it affects your readmission rates and the cost of care. We understand you can't, you send somebody home after a lap chole and they slip off the stairs, break their ankle, come back. You can't avoid that. But what you can avoid is a handoff of a CHF patient that's well maintained. Let's get home health in tomorrow. But if our home health agency gets the referral, there's no handoff. They find out about it on Monday. That patient got discharged Saturday. They're going to be back in our ER on Monday with fluid. So it really starts within our own organization. Convenience orders. Look, I understand. I hear it all the time. I'm a non-clinician. Lost a follow-up. We have this patient in the hospital. They've had this order for an MRI for 6 months. That really should be managed outpatient. We shouldn't be doing that MRI in the hospital. Let's coordinate that visit and get them here. Let's talk about transportation resources with care management. As soon as they're discharged, let's get them back to do it, because otherwise all we're doing is adding more healthcare costs in.
All right. Any other questions?
I'll add one comment to that, because Leonard did mention, I thought he was going to. I would blow up the regulatory piece.
Oh, listen to this.
We are, well, I feel bad because I wasn't.
Paul gets the extra wand.
I feel bad because Chrissy was brave enough to say blow up the whole healthcare system, and I wasn't, so I kind of feel it. But I would blow up the regulatory piece because, look, every single one of these rules that the feds make is based on, there's someone's face with a waste, fraud, and abuse claim out there somewhere. But you can't legislate common sense, and the problem is we've created so much cost structure around the regulatory piece to this in terms of how we get paid and how we do this, that, and everything else. I mean, now we're at the point where, payers are using AI to deny our claims, and we're using AI to appeal the claims, the claims denial, and we're just launching back and forth in the ether about, it's absolutely wasted time and effort. And if you want to lower the cost of healthcare, you can't ignore the regulatory expense that goes with this and how much money we spend managing payers and just trying to, the constraints it puts on creative solutions that you all have and you've heard us talk about. As long as some of these exist, we just keep breaking it over and over again and trying to fix it with the next piece of the next constraint and the next regulatory component.
Yeah.
Well, one of the things that you're going to hear in just a bit, when I told you about that 145 session, is a new partnership with us to actually start breaking some of those regulatory issues and address them head on in Washington, D.C. for us. But I want to take a moment, and I want us all, if you don't mind, to give our panelists a huge round of applause.